Next session, if I could invite our speakers to come up. You know who you are. Take a seat. And as they're coming up, I'll start introducing them. So we've got Associate Professor Clinical Clare Ramsden. You want to wave at us, Clare? She doesn't look like an executive, but she is one. So Claire's just started as the Executive Director for Operations in Southwest Sydney Local Health District, which is one of the largest LHDs in New South Wales. She says she's done a lot of big picture stuff like e-health clinical programs, whole of health, surgical performance, project management, redesign, that disaster mass casualty response, HAZFAC responsibility. But ultimately, Claire's a registered nurse who has lots of emergency experience, and I think you're an emergency nurse at heart, and you've remained so. And that's evident by her commitment to the emergency and trauma care textbook, which is often what's used in most of the universities for our training. Our next person who's sitting there, Adam Parker. So Adam provided a very brief bio that says he's the station officer, intensive care paramedic, peer support officer, Western Sector. What does that mean, Adam? You're in charge of the station out at Bathurst?
Just like most of us, just a part of the puzzle.
Right, but Adam was an emergency nurse, and we did our emergency nursing degrees together at Sydney University a long time ago. We've got Paul Hudson, like to wave there, from the Clinical Excellence Commission. He's a project officer there and does a lot of stuff with Between the Flags. And they're ultimately aiming to improve the recognition and management of deteriorating patients across our healthcare system. And before that, he spent 10 years working as a registered nurse in emergency. Either as a CNC, a nurse educator and a nurse manager. Next, we have Emma Bosker. There we go, thank you. So Emma is a mother of 7 and speaks from the perspective of the parent of a child using our emergency services. She's got a background in occupational therapy and family psychotherapy, and she's worked in various mental health settings as an occupational therapist and has a postgrad diploma in systemic psychotherapy. I don't actually know what that means. We've never had that conversation over a glass of wine. So she's worked a lot with children and adolescents and families in public health, and at the moment she's full-time mum bringing up her kids and is looking forward to getting back into the former part of her career once the youngest one's at school. And she's going to talk to us about an accident that has happened in her family and the care that she's been provided through our healthcare service. We've got... and she's my friend as well, so you've got to be really kind to her, I'm sure you will be. But you don't take the prize for the best kids story. Someone we had here yesterday has quadruplets, and she's one of the nurse managers at Wollongong, so we'll have to catch up. John Mckenzie. You met John before. He's an emergency medicine physician and has worked in Médecins Sans Frontières as well, primarily in Africa, and now works at Prince of Wales and the Emergency Care Institute. Oh, Joe Duflou, Professor Joe Duflou. Sorry, Joe. Joe's a senior forensic pathologist, so that's the morgue stuff, like on CSI. You're better looking, Joe, after... So he's Joe is a brilliant man and a great pathologist, and has an in-depth knowledge around mechanisms and effects of disease on the body, both in living people but also in those who have died. And he's... when the nasty stories are on the news or in coroner's court, or they're trying to work out what's happened to a patient, Joe's usually the person providing the advice in the background. And has always been a really strong supporter of clinicians as well, coming to morbidity and mortality meetings and things like that when he used to be in charge of forensics in New South Wales. And last but certainly not least is Brooke Parsons. looking very nervous there. And so Brooke's just beginning her nursing career, and she's got just over 3 years' experience and 2 in her special interest, which is emergency. So at the moment she's working full-time at Wollongong Emergency Department and also doing her Masters in Emergency Nursing, and she comes from rural New South Wales. So that's our panel, and the way it's going to work is some have presentations, some don't. They're all going to be talking about what I mentioned before, and it's outlined in your programs. And the slides are just going to come up as that person comes up, which are in order of the program. And we'll have a sort of a Q&A at the end. So we'll get started with Professor Ramsden. Thank you. Please welcome Clare.
Thank you, everybody. It's actually my privilege to be stood in front of you this afternoon. You're such an amazing group of nurses. Having experienced emergency and trauma nursing myself, I think you're all fabulous, and you should actually applaud yourself. So I would really like you to give yourself an applause. Well done. And especially Marie, who's 39 years of emergency nursing in Bowral, southwest Sydney. So thank you. So I just wanted to start off by saying, yes, I am an executive. You're probably wanting to throw daggers at me right this moment, in the sense that I sit in an administration role. But I just want to explain that I am one of you, and I'm not different to any of you here in the room today. I'm a daughter, I'm a sister, I'm a wife, I'm a mother. I'm a nurse of 34 years, not quite 39, and it is in my blood. It's been in my blood since I was 8 years old, when I told my mum I was going to be a nurse. I commenced my training in the UK in the early 80s, and I've travelled with my qualifications and worked as a new graduate in Australia back in the 80s. I returned to the UK and did my emergency trauma nursing, and my postgraduate qualifications are from the United Kingdom. My career pathway is that I did actually commence as an enrolled nurse, actually as a volunteer when I was 15, and then as an enrolled nurse, registered nurse, and then through the system to a clinical manager, nurse manager. So when I arrived in Australia in the mid-90s, I took the opportunity to apply for positions that I probably wouldn't have applied for in the United Kingdom, because I was so enthralled with the trauma in the United Kingdom, so I probably would not have left the clinical arena. So I started here in a new country, which gave me sort of a new outlook on my career, and I took this with both hands. So I've been a clinical nurse educator, so I've experienced everything that a clinical nurse educator would experience. I've been a clinical nurse consultant, and been a nurse manager in emergency services. I've been in positions as nurse manager of emergency critical care, director of nursing, LHD director of nursing. And what I'm not trying to boast here, I'm just saying our careers, we can actually really move quickly and transfer all that experience very quickly into many roles. So for the last 24 months, I've been in an operations position. So first of all at Nepean Blue Mountains, and now at southwestern Sydney, which is the largest district in New South Wales and is fastly growing, one of the largest and growing fast LHDs in New South Wales. So my leadership style has been described by others as authentic and adaptive, and I lead from the front, and I wouldn't ask anyone else to do something that I wouldn't do myself. Now, why did I go down the leadership and administration pathway? And it was to make a difference, to be in a position to influence policy that impacts on nursing and patient care. So I just wanted to say, I'm using Dr. Seuss, as that's probably that is the theme of the conference. So you have brains in your head and feet in your shoes. You can steer yourself in any direction that you choose, and we can as nurses. So from my perspective, the most important thing an emergency nurse should do is their best. For all their patients, be compassionate in the care that you deliver, And add those small acts of kindness. I had to get that in because, you know, it's part of health, so New South Wales Health. And be the advocate for the patient, deliver evidence-based care, be safe in the delivery of your care, and question treatment plans that are prescribed by the doctors. Be innovative and, most importantly, challenge yourselves. You may not remember the patient, but they will remember you. And the things you do and say will have an impact and be remembered. So how can I help you in my role in your role as emergency nurses? So in my position, which sits at the local health district level, I can and do assist you in many ways. Firstly, by having the experience of being a clinician and a nurse and having an understanding of the work that you do. How an emergency department functions and how it should function, understanding the language and your stressors. And this I take with me in all my work, whether I'm sat at the Ministry of Health in a meeting or I'm sat in front of the board members. I understand you and I am one of you, and I want the best for you and ultimately the patient. So how can she do this? I can hear you sort of asking yourselves. Well, I'm hoping you're asking yourselves. Through influencing statewide policy that enables you and the health system to deliver care, working with the pillars such as HETI, CEC and the ACI to ensure that initiatives are able to be implemented and make a difference. But my role as an executive is to support the general managers throughout my district, to lead and manage their hospitals to deliver services that meet the needs of our community and staff. So my utopia, so if I was to redesign the health system where everything was perfect, what would that look like? Well, we would have a safe, effective health system where everyone has timely access to care, where we have robust systems and where we have where we are reflective on care, and hence the empowerment concept that I've popped there. We would have robust systems where we are reflective on care and admit when we've gone wrong and correct it as a system. We would have more care in the community. We would shift more care back into the community. And following on from John, technology changes so quickly. So my utopia would be that we'd have artificial intelligence and robots performing all surgery. I can dream. With no post-op complications or post-op stay. The surgical beds could be then reconfigured to medicine, aged care and cardiac. And that would solve our access issues. Ambulance offload would be above 90% and our ETP would be at 100%. So the pressures on emergency departments would be reduced and we'd be able to look after you much better. Thank you.
So, my name's Brooke and I'm a third-year registered nurse, just under 2 years' experience, 1 year, 9 months, not enough to win that prize this morning. So I was asked to talk today to provide a junior nurse's perspective of what it's like to work in ED. I know there's probably not much I can teach you, but instead today I'd like to remind you of what it's like, because everyone's been in my position at some stage. So nursing's probably not something I said I always wanted to do my entire life. I knew that I wanted to work in health and help change people's lives for the better. I went through many options, very indecisive as a teenager, doctor, dentist. I even considered podiatry at one stage, but then thought about it and realised I was just chasing the salary. So at the end of year 12, Mum convinced me that nursing would cover most bases in healthcare. So 2 weeks after my 18th birthday, I moved 6 hours from my rural home in New South Wales to Wollongong, where I started my Bachelor of Nursing. 6 years later, and I haven't looked back, and I know you're all calculating my age now, thinking she is a baby. Well, all of my patients agree with that, and they tell me that all the time. So after a year of the wards and then 2 in emergency, I've certainly learned a few things recently on what others can do to help facilitate the growth of new nurses in ED. I'd like you all to think back to when you started, whether that be 5, 15, 39 years ago, and think about how you felt when you were first on the floor. Personally, I was so nervous. I had a million things going through my mind, like would I keep up with the turnover? Would I be able to prioritise things properly? But starting was one of the most exciting and nerve-wracking experiences that I've had in my life. Every day I was actually jumping out of bed, so keen to go to work. I knew I loved critical care, and I've never been like that before with work. So every day I was excited of what things I would learn, what new experience that I'd have with all the patients that had come through the doors that day. But then with contrast to that, as a new grad, I'd had some bad experiences with senior nurses not wanting to help me explain things because it was too busy or they just didn't like teaching. It was very much a sink or swim scenario, and I prepared myself for the same thing to happen when I started an ED, but it didn't. I was welcomed effortlessly into their team. The best advice that I was given when I started an ED was a little bit cliche, but they said to me that all good nurses make mistakes, and if someone tells you that they've never made a mistake before, they're probably not a good nurse. The key thing was that they were trying to explain to me that honesty and good communication is key, and feeling comfortable to own up to your mistakes is probably one of the most important things in ED. Actually, at the time, a lot of other nurses chimed in, and some I thought, you're sounding a little bit too proud of that mistake that you've made. But the point was that they wanted me to feel comfortable that I didn't know everything, because even if you're a senior nurse, you're still going to make mistakes. I've had some wonderful mentors that have guided me since I started an ED. They took the time to push not only myself but other junior nurses to grow and really progress through emergency. I think one of the biggest things is choosing your words wisely, because it can really make or break someone's day. Some days I felt like I've done really well, but then other days I've gone home completely deflated after how I've been spoken to, not only by some patients but also by other colleagues. I think your confidence can really take a hard hit if someone's outright impatient with you or they're communicating poorly. ED is a busy place to work, but if we're not supporting each other, not only does the individual like myself or other nurses suffer, but the entire department falls apart. Nursing and healthcare in general is a profession that's always going to be progressing. That's why we're here today, to continue our professional development. Everyone starts as a junior like myself, but the main difference, while I have 2 years experience, you may have 30. Try to remember next time you're teaching a junior nurse that you were in our position before. We're scared of doing the wrong thing, of not being fast enough, not articulating ourselves quite as eloquently as other people, not handling conflict very well, or asking too many questions. But the only way we overcome this is with experience and confidence in our ability, which is a direct reflection of the team that we're working within. As a junior nurse, we bring enthusiasm to the workplace. I think amongst the chaos and stress, it's the juniors that really are thriving on the new experiences that come through the doors. We get a lot more overwhelmed than the seniors do, but that's where your support is essential. We bring the gusto, but you also bring the stability. Having juniors in the department is grounding for everyone, and in us, I think you can see the reason that you chose to start an emergency in the first place. I think it's difficult to describe our utopia because ED is always going to be an unpredictable place. As a new nurse, I think the most important thing is having a supportive group to work with. My own department, like many of yours I'm sure recently, has been inundated with a lot of high acuity patients, and it's really hard to cope. But while our environment is out of our control, how we show up each day is our choice. I think the big thing for me in my department is how our manager has treated us. She shows that she appreciates our hard work, and she's very understanding of what it's like. She sets the standard not only for the juniors, but how the seniors come to work too. I think the mutual respect that we strive for is what helps us show up each day, even when we know it's probably going to be an absolute mess. I think that 1/3 of our life is actually spent at work, and we've chosen a highly stressful workplace. So my utopia is knowing that 30% of my adult life will be spent in a fun and supportive environment. Thank you.
I'm Joe Duflou, I'm a forensic pathologist, and my plan was to ad lib. And then, unfortunately, I lost courage. So I now have a couple of pieces of paper and an iPhone to talk from. Okay, so there we go. Who am I? I'm a forensic pathologist. Why am I a forensic pathologist? It's all a very tragic story. It started in 1965 when I had measles. And there I was lying in my grandparents' house in Belgium. And I was feverish and delirious and all that. The GP came along. GP still came to your house in those days. And I have no idea who he was. And sooner or later, a relative came along as well. They'd heard I was sick. And a relative sees a 7-year-old child. Yes, you can work out how old I am as well. And doesn't know what to say. They say, what do you want to be when you grow up? So the previous person I'd seen was a doctor. So I want to be a doctor. Give me lollies. And unbeknown to me, relatives wrote down, we're going to have a doctor in the family. So there we go. Next day, another relative arrives. News got out. And what do you want to be when you grow up? This was 1965, remember? So I said, I want to be an astronaut. I hadn't seen an astronaut the previous day, but, to say, didn't you want to be a doctor? And so in any case, years go by. And all along, it was decided, it was decreed. There was no doubt about it. I was going to be a doctor. At the age of 16, when yet another report card came in, you're going to be a doctor. I finally plucked up the courage and told my parents, I don't want to be a doctor. I want to be an accountant. Truly, I wanted to be an accountant. Numbers are beautiful things. They dance in front of me. They really do. If you want me to get really passionate about something, show me some numbers. So there we are. So I wanted to be an accountant. I got a clip across the ears until I was told, you will be a doctor. So I became a doctor. I said, I don't like being a doctor. And I've got to honestly say this. I don't like patients. You're not meant to say this. But I don't really like patients. So it was a matter of, okay, what can I do? So looked at the list of specialties. I know, hospital administration. But that involved people as well, so didn't like that. Radiology, now that's got potential. Yeah. Anesthetics. And then I thought, no. The answer is pathology. And specifically, chemical pathology. And the reason why chemical pathology is they're machines, they churn out numbers, you manipulate the numbers, the patient becomes truly a set of numbers. And you never have to see a patient in your life. And it was perfect. So I applied for a job as a registrar in chemical pathology in the absolute certainty that I would get the job. I didn't. I was shocked and horrified and devastated, frankly, and this just wasn't according to the plan. The thought of you actually not getting the job you apply for just had never occurred to me, that other people might apply for it as well. So I didn't get the job as registrar in chemical pathology. So then I started looking around for a job and I couldn't find any. And my hospital administrator at the time said, I've always wanted to be a forensic pathologist. Now this, I've got to point out, was in South Africa in the 1980s, the early 80s, bad years. And I said, you are kidding. It involves, frankly, complicity with apartheid regime, blah, blah, blah. I'm not going to do that. But he said, no, you really should. To which my response was, well, why don't you go and do it? No. So, but in the end, he nagged and nagged and nagged me. I think he wanted to get rid of me. He realized my skills lay elsewhere, as they put it. And hopefully I would go far away. So sooner or later I said, look, okay, I will phone I will ask if they've got a job. They won't have a job, and that'll be it. So I phoned and said, when can you start? Okay. So, well, I hadn't learned to say no yet. I still struggle with that. And so I landed up doing forensic pathology for a year. And, I sort of never got out of it. So there we are. That's how I became a forensic pathologist. Sooner or later, I landed up at Glebe, Department of Forensic Medicine. I was able to knife enough people in the back to get to the top of the pile, et cetera, et cetera. Then sooner or later there was, yet another restructure. That was 2 years ago. And since then, I've been in private practice. The initial aim was, in fact, to be in semi-retirement. I've worked harder than I ever have before. And just for good measure, at this stage, I'm also doing most of the coronial autopsies in Canberra and surrounding New South Wales. Tomorrow, I'll be doing 6 autopsies there. I'll be waking up at 5 o'clock in the morning, which means that I'm really in retirement mode. Okay, so there we are. So that's why I'm a forensic pathologist. It was all a tragic mistake, in short. What are the most important things that emergency nurses need to do from my perspective? I'll read you the list here. Clothing and personal effects. Don't lose them. Being by far the most important. If you're going to remove them, preferably, and I include ambulance officers in this, don't cut through the damage in the clothes. Do not join up the stab holes, wounds in the clothes. Okay. Next, use an environment free of DNA. So make absolutely sure that between each patient, you bleach the entire emergency room, have only one patient in that emergency room at any one time, and just make sure that there can be absolutely no contamination of any surface or any patient. Okay, good. On a slightly more serious note, please take photographs often of your patients. There's nothing quite like being asked an opinion on an injury weeks down the track when the cursed thing has healed and all I see is a scar. The earlier the injury, on the surface of the body especially, the more information it provides in terms of trying to work out what happened. So photographs are my friend. They should be your friend as well. If you are going to take photographs, make sure they're in focus, please. Don't touch the injuries, ever. Leave them alone. Now, there's a bit of a problem there with patients and what will happen if you don't touch the injuries, but from my perspective, I like a beautiful, fresh injury. I do not like one that's touched. I especially do not like injuries where surgeons have done things to them, like, let's do a laparotomy. Oh, there's a stab wound in the abdomen. Let's include the stab wound in the laparotomy incision. Oh, here's maybe a gunshot in the throat. Let's use that as a tracheostomy. Now, you might think that's funny. That's probably what happened to JFK, to Kennedy, and ever since there's been controversy as to whether he was shot there or not, or who knows whatever. But seriously, the number of injuries that we land up with, where why couldn't you just go next door to it? It really does make a very big difference for us. Please get the terminology right in terms of injuries. Stab wounds are stab wounds. Lacerations, this is where I show off my Latin knowledge from school. I nearly failed that. Lacerare means to tear. It does not mean to cut. Lacerate is a tearing injury. Stab, incision, cut is a cut. Okay, there is a difference. Don't remove medical goodies. So, drips, etc., ET tubes, you name it, we like those. And every so often we can use them later while we design our own equipment in the mortuary. So we actually do sometimes put things together to try and work out how to do things. Keep records. 2 further things. Teach surgeons to count. Okay, now there's a very good reason for this. And there's a beautiful study in which there's a comparison of number of bullet wounds as determined in the emergency department versus number of bullet wounds as determined by the forensic pathologist. Considering that to enter into the study you had to be shot at least once, they were pretty good at getting 1. By the time there were 2 holes, they were sitting at 50% right. 3 or more holes, they had no chance. They can't count. They were never going to be accountants. They were definitely never going to be forensic pathologists. They were always going to be surgeons, okay? So that's a problem. Seriously, what it's about, of course, is documentation. Finally, don't assume the coronial system is your enemy. Okay, we actually do try and help. We are there to provide information. Just ask. Okay, we really are available to tell you what happened, as far as we can tell. And if you think we are not right, which I'm more than happy to admit, I get things wrong, please tell us. Because you will probably have information that we don't have. In terms of how can I help you? Yes, well, I can provide you with information in relation to autopsies. I can inform you on what was present, what wasn't present, what may have gone wrong, what didn't go wrong, where the treatment did help, where it didn't help. Finally, our utopia. Now, I used to be a public servant and I'm no longer one. So I'm really impressed to have a lanyard. I mean, surely you used utopia on purpose here to refer to the TV show. Considering that I now work essentially part-time in Canberra, which is public servant heaven. It really is. To me, that is truly like in the TV show. My utopia, I think I've pretty much gone through it, what I would like. So I'd like no patients in emergency departments at all. I would like surgeons who can count above the number 2. I would like beautiful medical records. I would like photographs of every single injury as the patient comes through the door. I would like the examination of that patient prior to any treatment having been administered to have taken probably about 3 hours, and everything being documented in absolute detail. Okay, thank you very much.
Good afternoon, everybody, and thank you for the opportunity to have a chat to you today. I did prepare what I was going to say, but then listening to the conversations and the lectures today, I've had to pretty much change most of that. So let's see how we go, and we'll run it there. So as Kate mentioned, I have an emergency nurse by background. I worked at RPA, and we're in a very similar position to everybody here in this room. I got my enthusiasm for quality and safety as an emergency nurse. It was an ever-changing environment, and I assume it still is, and we had a great team that wanted to improve what they were doing, that wanted to be there for the patients they wanted to do, but struggled with how to do it in that way. Similar to many of you here, a couple of years ago, I presented at a senior conference on quality improvement initiatives, and I wanted to do more. Which led me to getting a position at our Clinical Excellence Commission in New South Wales. So, like with eHealth, it is a New South Wales pillar organisation. We may not think that it's relative to our interstate or international colleagues, but in some respects, and I'm happy to say that we do share everything that we do free of charge, in majority of cases, to interstate and international. Between the flags and sepsis, which is probably more well known than the CEC itself, in many instances has used in WA, up in Queensland in some respects, down in Victoria and Melbourne, and overseas. And we're quite proud of that in that respect. So that's where we're sort of, that's our sort of role in our healthcare system. Now, how do I move the slides? 3. So I actually flip this around a little bit, and I want to talk about a utopia first, because this sort of aligns with our vision, our CEC vision, and which is that our health system provides the safest and highest quality care for every patient. Now that is a very, high level, top, probably unrealistic sort of aim. But if we don't start there, how are we ever going to achieve it? Let's exclude all the barriers that affect us, because we don't, all barriers are going to be there all the time. We're always going to have to come across these barriers, but how do we focus back on the patient to deliver that high quality care? And I think that is something that everybody here wants to do every time they go to work. They go to work to provide that excellent care. And one thing I want to pose in you at the moment is, does everybody do the same? If you just contemplate that for a second. So you go in there, do work, you do the best you can. Your colleague does the same intention, but is that the same result? We're looking at reliability of what we actually deliver. Through reliability, we can actually start to improve what we're actually doing and being consistent, and also have some sustainability. Now, considering the environment, and we know that this is ever changing, you've got increasing pressures year on year, and that's never going to end, particularly at the moment. This is also no small task, but improvement and to change things, that's something that we always have to strive for. And unfortunately, there is no one single bullet that is going to address all our issues. So a chart is not going to solve a problem, a pathway is not going to solve the problem, e-health is not going to solve the problem. Okay? They're just tools at our devices to try and help us and support us. One of the main and important things that will impact improvement and ongoing improvement and sustainability is actually leadership. Without leadership, you're due to fail or not have a sustainable impact. So that comes down to what emergency nurses can do for everybody else and for us. Those in leadership roles, continue leading. There's been great examples in the conference and in being presented of great leadership in quality and safety. Continue to do that, but go the extra step. Identify the juniors in your department and work out a way how to nurture their skills in leadership. It's not something that we are taught. It's something that we mimic of our leaders, of the people above us. Everybody in your department has an opportunity to lead, whether it's just in an area in their department for that particular shift, working with somebody else, or it's controlling the whole department itself, or it's going even further and looking at the hospital side. Look at ways of how you can create a psychologically safe environment where ideas are free-flowing, where they're not shot down, that everybody can stand up, particularly your juniors, and say, I have an idea, let's give it a go. I actually really resonated with Brooke's talk about people having, speaking it down and feeling terrible. Work out ways how that is no longer acceptable. Because in doing that and supporting that leadership, you'll actually start to develop that culture in your organisation. And with good culture, good leadership, improvement will be free-flowing. And so that was my challenge to you. So, on the other side, what can we do for you? It's not just me, there's a whole CEC behind you. As I said, we freely give our resources to all our external colleagues, and we're actually undertaking some work with Queensland and Victoria and ACT with some collaborative works, not in within paediatric sepsis, so some of the EDs in this room might be involved in that, and also in other initiatives. So we're working in those spaces to help do that. But with the CEC, we actually try and work in partnership with our LHDs and our organisations. And the improvement in New South Wales hasn't occurred overnight. It's been over a decade journey. We've built the blocks for our system to try and make it better. Where we started is actually looking at our intelligence. What information can we gain? So, as you said, looking at RCAs, incident reports, they all come to the CDC and they're all, reviewed and categorised. Looking at our surgical and anaesthetic data. Yep. QSA, quality of information. And they have actually integrated where our projects have lied. We all realised nice and early that leadership and teaching leadership and quality skills wasn't important. So that is something that has happened at COOL as well. And then the projects have actually evolved. As soon as you implement one, other issues start to arrive. There's a great quality culture in New South Wales because we actually get a lot of incident reports. That's actually a good sign. A lot of people reporting, that's what we want to see. We want to see the deaths going down, but we want to see lots of reporting. We're actually now moving to a space of more clinical analytics and intelligence and how we can actually better get the information to the bedside and to the clinicians there. A couple of ways that we do that is, first of all, direct emails if there's an urgent issue, and an example of that was with the nitrous and oxygen gas incident that happened in our LHD. And within a couple of days, every one of those gas cylinders across the state was checked to make sure that that wasn't happening anywhere else. So that's something that we do. The other things is the safety notices, looking at recalls of products, drugs and equipment. If it's happening at one end of the state, we let the whole state know so they can double check. More recently, we've been looking at patient safety watches. So these are emerging themes from our RCAs. And so, as John mentioned, there's headaches and AAA's misdiagnosis as emerging themes. But other emerging themes which are coming up in EDs are people being discharged without their symptoms being resolved and not being reviewed by a senior member of staff. So these are RCAs, so these people actually died in that respect, and being discharged with their observations abnormal. Things to look at. Other issues with that is unfortunately, mental health, which is a very challenging area at the moment. But patients being in category 2s and going to the waiting room and then absconding. You can just see it happening in front of your eyes, and there's many issues why that might occur. Where we're looking at is now the microsystem and our focus on change. So we're trying to build and help people develop those psychically safe environment. We want you to start to learn about your systems. Every system in the healthcare system, every system in your department are slightly different. Don't assume that you know how your system works until you actually start looking at it. One thing that we've advocated in the release of Between the Flags is that EDs write down their emergency response system and their responses. And then they said, that's what we do every day. And then as you start looking at it, you go, that's not what we do every day. Whoops, okay. Understand normal variation, because there is normal variation, it's not going to be the same every day, and special cause. And start to think about, understand, is this change an improvement? Right? Learn from the things learn from your failures and learn from your successes and build on that. PDSAs can be done in rapid cycle every single day to create change. Thank you very much.
Thanks everyone, good afternoon. I'm very aware of the time, so I will try and make this quick. It's nothing like going at the end of the day. I feel very honoured, so thank you very much to everybody for the invitation to present today. So who am I? First and foremost, I'm a father of 2 beautiful boys, and I'm very, very happily married to my beautiful wife, who, as it happens, after working for the majority of her nursing career as an intensive care nurse and us having lots of very robust discussions, she is now an emergency nurse as well. In fact, she's an educator at our local hospital. Kate, I told you I'd get that photo in. This is Kate and I. I'm also a registered nurse. Yes, I'm not quite sure what happened there. That was pre-children, that photo, so maybe that's got something to do with it. But I started my nursing career working at Ryde Hospital. I worked interstate, and majority of my time was spent at Westmead Hospital. I think my experience as an emergency nurse has definitely contributed to my paramedic career. I still look back very fondly on my time as an emergency nurse, and still draw on a lot of those experiences today. I did, however, feel that there was still something lacking, something not quite there, and that's when I made the decision to move across to the pre-hospital environment, which I'm obviously still doing today, and I love more than ever. It definitely was the right career move for me. I've seen some amazing things, been to some amazing places and had a lot of great experiences, and I feel quite at home. I'm an intensive care paramedic, as Kate said. I work out at Bathurst. I've been at Bathurst for the last 7 years. I have spent 8 years working in Metropolitan in Sydney West and Sydney North, which was kind of like home to me, so I really enjoyed that time, but it was time to move on, so we moved out into regional New South Wales. I've had many roles in ambulance, management roles, education roles. I think I am an educator at heart, but one of the roles that I've had is teaching our volunteer ambulance officers out in regional New South Wales, and that photo that's just popped up is two of our longest serving volunteer ambulance officers out at Manildra in New South Wales. They're very special ladies who have around about 60 years experience between them. I also work as a casually as a lecturer and educator with Charles Sturt University with our undergraduate paramedic students. I'm very passionate about that because, similar to experiences that have been mentioned previously, I remember when I first started nursing being given a very hard time by a couple of old dragons who simply because I was a university graduate. So I swore not only was I never going to treat anyone like that, but I was also going to work really hard to make sure that they were the best nurses or the best paramedics that they could be. And that's my other passion, emergency management as well. I am involved in a lot of our emergency management across the state, and most recently the Bathurst 1000, obviously. That's not why we moved to Bathurst, but it is good. So the most important things emergency nurses can do. I think first and foremost, after chatting to a number of my paramedic colleagues, the same sort of themes kept coming up all the time. And probably the most important thing was listen. And I think particularly around triaging. I'm certainly aware of the stresses on emergency nurses, particularly triage nurses. I'm also aware of the focus and the pressures on you to ensure that you complete your EMR, get all your work done. But I think if you actually just took the time to engage with the paramedics rather than focusing on the EMR, I think there's quite a lot of valuable information I think that we have. Look, I know some of us can waffle on a bit, but I think we've done a lot of work over the years on clinical handovers, and I think we're in a pretty good place at the moment. But there's a lot of information you can pick up. We bring a lot of information in, and not just about the patient's clinical presentation, but a lot of relevant background information too, like the elderly lady who slips and falls at home and fractures her hip, who probably hasn't seen a doctor for the better part of 15 years, and that's her bedroom. It was dirty, my boots were sticking to the floor, there was excrement around the room, it smelt. I don't think she'd had a decent feed in a long time. So, all that sort of information is really, really important. I remember transporting a patient to Sydney only about 6 months ago, and I don't think the triage nurse actually looked at me the whole time I was handing over to her. And that's kind of what really got me thinking. So, it doesn't take much, and I do think we can value add to that patient's experience. Respecting our decisions too. I think, we may not always be right with our transport decisions, but I think, there's usually a rationale behind why we take patients to where we take them. We don't just, drive around the streets as some emergency nurses think, skull dragging people into the back of the car and taking them to hospital just for shits and giggles. There's usually a good reason why we do it. I think appreciating the environment that we work in. I really think we are all doing the same job. We're all part of the same team. And certainly today, after hearing a couple of different experiences, particularly around processes, systems, EMRs, I'm certainly learning that our problems are very much your problems and vice versa. A lot of the impacts on how we do our job, where we do our job, out our way in Central West New South Wales, we have 4 very distinct seasons in 1 year. It's not uncommon for us to be responding to patients who are isolated and in snow, for example. So we use our 4-wheel drives, and that has all sorts of problems associated with that. That's not the best photo, but working in confined spaces, trying to treat patients, get information, package the patient the best way we can, has constraints, and confined spaces, getting patients in and out of these spaces can often be very difficult. And obviously, major trauma situations too, like the patients... it's another, being exposed to all the elements. That particular job was at about 2 or 3 o'clock in the morning, and there was 4 young people trapped in the car, 2 of which were unconscious. So, there was lots going on. We only had limited resources. So I guess just being mindful of those sorts of elements to our job can be really, really useful. How I can help you? Well, I think we can help you by providing really good, thorough clinical handover. As I mentioned before, it's something we've been working on a lot the last few years in ambulance, and I think we're doing quite well. But obviously, as far as you, the triage nurse particularly goes, I think, providing a good, thorough clinical handover, not waffling on about a whole heap of irrelevant stuff, but making it really succinct, concise, and obviously meaningful. Not giving you excuses. And by that I mean, we picked up this patient, yeah, sure, they were just around the corner. I thought you might appreciate that. If nothing annoys me more than hearing any of my colleagues come in and say, look, we didn't cannulate that patient, we were just around the corner, and you've got a clinically dehydrated patient who looks crook. We didn't put a line in and give that patient any pain relief because, we were only 3 minutes away. You shouldn't accept that. And we shouldn't be offering those sorts of excuses. One of the things that upsets the most is when we go to a nursing home and you go and try and find someone to give a clinical handover, and more often than not in a nursing home, and I don't mean any disrespect, but usually it's the cleaners or the ancillary staff who provide us with more meaningful information about patients. But when we do find a nursing staff member, being told by them that they've only just started their shift, or, look, I've only just come back from leave, I'm not really sure what's going on. Nothing frustrates us more than that, and I shouldn't expect you guys to have to tolerate that either. I would encourage you to come and have a ride along with us. It used to be done a long time ago, not so much these days, but come and ride along with us. Experience what we experience, walk a day in our shoes. You'll appreciate that there's a lot that we do that's very much the same. We just do it out of hospital. And if you haven't seen us in a few hours, it doesn't necessarily mean we haven't been doing anything. Some people get the perception that we just sit around on station and watch television, which isn't true. Not always, anyway. But it's highly likely we might have been involved in another incident. And I have been known in the past to do the odd Macca's run, particularly on night shift for my nursing colleagues in the ED, and maybe even once or twice urgently. My utopia would be taking my patient into an ED and having empty beds. Having plenty of staff around. That way I would only have to actually hand over once, not 3 or 4 times. Having the teams admit their patients. And once their patients are admitted, having the patient gone out of the ED. No access block. There's nothing worse than half an hour out from the end of the shift driving into the hospital and down the ramp to the ambulance bay to see a chock-a-block full of ambulances and know that tonight, again, I'm not going to be home for quite a few hours. Control centre. So our control centre staff, having systems in place that prevent a lot of these crap 000 calls from actually getting to us. So putting systems in place that stop these jobs so we're actually doing real emergencies. A room designated for coffee, not just for us, but for you guys as well. and cake. Everyone loves cake. So thank you very much.
Hi, good afternoon everyone. My name's Emma Bosker and I'm here to give a parent perspective on emergency nursing. Thanks to the emergency staff at Wollongong and Sydney Children's Hospital, my son Seb is alive and well and making amazing progress. Without their skill and quick response, Seb would not be here today. So we were honoured and slightly nervous when Kate asked us to give a small talk. So this is the story of a terrible accident that happened to our 3-year-old just over a year ago. It starts with the kids and myself coming home from holiday, July last year. My husband stayed back home whilst we were away, and unknown to us, he cleaned the bathroom drains with drain cleaner, otherwise known as caustic soda. It came in crystal form, and so he used an old lemonade bottle and cut the top off to dissolve the crystals. He emptied and rinsed the bottle, but a small amount remained. And when we got back, Seb followed his sister upstairs, saw the lemonade bottle at the top of the stairs and drank this last mouthful that remained. Obviously, my husband had intended to just dispose of this bottle, but he forgot. Seb started to vomit immediately, and so we called the ambulance and the poisons hotline. And after the initial assessment in emergency, they decided to carry out an endoscopy. On the way into theatre, Seb developed breathing difficulties, and so they intubated him immediately. I believe the swelling in his esophagus was constricting his airways. Several hours later, we were choppered to Sydney Children's Hospital ICU, and we came home about 2 weeks later. It was a watch-and-see situation, as he was cautiously eating, and we needed to see how he would continue to heal. Sadly, though, the healing esophagus formed a long, tight stricture, and during the next 4 months after we were discharged, we became increasingly concerned as it was getting just harder and harder to keep Seb nutritioned. I did express my concerns to the doctors on several occasions, but since Seb looked so well and hadn't really lost much weight, they were not really overly concerned. We attempted 3 barium swallows, but could not persuade Seb to do any of those swallows, and the gastroenterologist's smallest camera was still too big to manipulate down Seb's esophagus. So they had no definitive imagery, and therefore everything was speculative. So why was I not... Oh, sorry. The next time we presented at emergency was frustrating. It was a Saturday, and Seb was beginning to dehydrate due to the formation of this stricture. Why was I not able to make myself heard the day before when we came to Sydney Children's Hospital for another attempt at a barium swallow? I remember a nurse there saying to me, "Are you okay?" And my response was, "Yes, I'm okay, but my little boy is not." Seb looked so well. I think they presumed I was exaggerating the severity of the situation, and it was only on presentation to the GP and with his backing, and this was on the Saturday morning, that Seb was assessed, admitted and put on IV fluids. The following day, on the Sunday, Seb went into surgery and a gastrostomy button was fitted. What are the most important things, then, emergency nurses need to do, from my perspective? To listen and inquire. When talking to the parent, to get an accurate history and a detailed account of what has brought the child to emergency services, it is really important that the nursing staff are non-judgmental, compassionate and inquisitive. They will get more clarity and accuracy if they connect and are warm towards the parent. Though nurses are the expert in their field, the parent is the expert on their child. I imagine that accidents represent a significant proportion of the presentations to emergency. I know that guilt played a role with us, and I wonder if this may compromise the authenticity of what a parent shares with the emergency staff. Parents don't need judgment from nursing staff. I'm sure they are harsh enough judges on themselves. An accident is precisely that. It was not intentional and was never meant to happen. For nurses in emergency, you need accurate, succinct, yet full and relevant information from a parent. So be compassionate for that family. You're seeing them at their most vulnerable, and however they appear outwardly, they may just be a mess inside. This makes it harder than usual to gain all the important information you need, but that is what you have to work with. I sometimes overhear misunderstandings on the part of parents and medical staff, and I recall one instance where a mother and her son were saying that no one would be able to collect her son after day surgery, so could he go home on the bus since she didn't drive? They told her that this was not appropriate, that anything could happen to him on public transport. And I was talking to her and realised that she was also going on the bus with him, but the nursing and medical staff had not realised this. She was shocked that they would even think that she would let her 13-year-old travel alone on public transport after an operation. And everything was fine once she explained to them that they would both be on the bus going home together. The importance of accuracy applies when nurses relay information to medical staff. They need to be extremely accurate in everything they hand over to the other health professionals. And in my observations over the 5 or 6 days we spent in ICU, the nursing staff in particular were extremely observant and very accurate in absolutely all handover conversations. Whilst Seb was in ICU, we noticed a small red spot that maybe could have been a mosquito bite. Within half an hour, it had turned into a rash and was spreading down his leg. The ICU nurse was already onto it, and my point being that small observations of something that might otherwise have been perceived as insignificant or meaningless are crucial when working in ICU or emergency. Aside from listening and relating to parents and patients, nurses need to assess and reassess what parents need to know, want to know, and how much they can take on. For me, I was very glad to be told a prognosis for long-term possibilities. And whilst at Wollongong Hospital, after they had stabilised Seb, but before we were chopped up to Sydney Children's Hospital, I was told that Seb, worst case scenario, he may never breathe without breathing apparatus, he may never eat properly again, and his voice may be altered from damage to his vocal cords. Best case scenario for Seb would be that he would get off scot-free, but the educated guess was that he would be somewhere in the middle. Once we got to ICU, I was told that this would be a long-haul rehabilitation process. I found that having this overall view very useful to have these long-term goals discussed. But after a very long 72 hours, my husband and I were told that they would get Seb through this. And that, for me, I think was the first time I was told clearly he would live. In retrospect, I think I was too frightened to ask in case the answer was no. Maybe that was the earliest point at which they were able to give me that reassurance. I'm not sure. Being told your child is stable is not the same thing as being told your child will live. And at times I think parents only hear positive things and don't hear the negative things. And for others, I think the reverse may be true. It simply depends on where the parent is at that point in time. There's nothing wrong with giving realistic hope when outcomes are unpredictable. I think as nurses, you are well placed and skilled in helping parents understand what they want to know, what they can take on board about what is being said, and work out with them what remains unanswered. There is so much more to nursing OBS than simply carrying out your OBS. As first point of contact, your observations and assessment are critical in the initial diagnosis and triage, and they are essential in enabling the full description to be brought forth by parents, family, and they are invaluable in gauging how a family navigates through the always traumatic, often enduring, and frequently unknown path after a child has become critically ill. I do think that the quality of nursing care has exceeded my expectations, and it has been a very high standard. I've felt such warmth and compassion from nurses throughout our journey, and it is clear that all the nurses we've come across have loved their job and they really take pride in their work. So in my utopia, an introductory question might be, we're here to get the best outcome for your child, and for this to happen we need to know as clearly, accurately and succinctly as possible what happened. What else might be relevant? What would your child want us to know if they were able to articulate their needs and fears? And would it be helpful to know long-term prognosis, or do you just want to deal with things one step at a time? I am my child's advocate, and I believe as such I need to educate myself on the medical process, the medications my child is taking, and the treatments that he receives. Sadly, sometimes things do get missed or forgotten about, and as a child's advocate, one needs to be fully aware every step of the way to make sure that any human errors get picked up on quickly. I should also add here that English is my first language and I have some health and medical background, but for some parents, advocacy for their child may be a much harder thing. And so finally, if a parent does question you, it's coming from a place of love and care for their child, nothing more. Thank you very much.
I don't think I can talk now, but I'll apologise now. That was fantastic, Emma, a fantastic story, and my life is slightly more flippant. There we go. My medical career has been bookended by emergency departments. It started in the 80s. In this place, Wellington. In actual fact, while I was having a cup of tea out there, I was talking to Jill, who also came from Wellington and probably worked in the same emergency department. So if I tell any lies, Jill, just keep quiet about it. Back in the old days, emergency departments were run by emergency nurses, and they used to put in interns in an RMO, and they'd have somebody running the place who was probably well-meaning but not necessarily well-trained. And I remember the process of turning up there where you would start doing your work, and the patient was seen by the triage nurse. They would make the diagnosis and decide what was going to happen, and then one of the ED nurses would sort it out, and you were kind of like a speed bump or a hurdle in between, and you would take time documenting and doing blah, blah, and sticking the cannula in your own skin and all that sort of stuff. And then they would get admitted, and we finished thinking that we were pretty good. I liked emergency so much I deliberately swapped out of the surgery term and did another term of emergency to get good. But one of the reasons was that was me. That was me 2 weeks before going into that emergency department. That was taken at graduation. So you can imagine that photograph, they always take photographs after you've been up for 24 hours and you're full of attitude and the breakdown products of alcohol. So this is the guy that's looking after your families, not necessarily, it was the nurses that were. But one of the reasons that we liked doing emergency in those days was because of this. We used to do a lot of really, really fun stuff, including intracardiac injections. I personally have stuck adrenaline into about 6 hearts. So I'm not sure if the wonderful professor who is looked at a lot of resuscitation, but back then resuscitation was full of stuff. It wasn't that successful, but it was full of stuff. I moved on and started taking my medical career seriously and became a professional ski patroller. And emergency nurses played a significant role in there because I'd had my 18 months experience as a junior doctor and knew an awful lot about medicine. But unfortunately, people were really sick on the mountains when we were doing, particularly in New Zealand, we used to fly to different parts and rescue. And I was saved, and my ass was saved by 2 great emergency nurses, one with ICU and emergency experience, Wazza and Perry. And without them, I would probably be in jail. And I wouldn't have been able to stay there for 3 years enjoying all of the academic advantages of working in a ski field. After that, I moved to Geraldine, and that's a beautiful little town just down the road from that mountain there, and became a GP. And once again, my imposter-like career was saved by a very good nurse. And she kept me alive and out of trouble for 8 years and none of our patients. And there's a bit of a theme like that. At some stage I was thinking that I needed to get a job, so I decided to go to Africa, where even more importantly, emergency nurses who predominantly go and work in these roles in conflict-affected areas. And one of the most memorable experiences was myself and a GP stroke surgeon, not a qualified one. And in Holland, they do a 2-week course on surgery, and we also had Taylor's book of surgery for remote places, and we were doing an emergency caesarean, and at the top end of the patient was a nurse anaesthetist stroke emergency nurse stroke midwife, and she gassed the patient while we were floundering around turning pages in the books, and pulled the baby out and then popped down the other end, looked it out, resuscitated it and finished up our mess, and the mum survived and the baby survived, and she shouted us to a bear afterwards. So I was thinking, where do I go from here? I can't go anywhere where there aren't emergency nurses, so I've got to go back to the emergency department and retrain in emergency, and that's what I did. And I ended up at Prince of Wales Hospital, which is kind of like a sheltered workshop compared to a lot of places where people work, and I'm going to find it very hard to leave there ever again. We do have wonderful emergency nurses, and it's a great place to work, so if ever you want to come and have a break, come to us. It does get busy, and we are hard-working though. So the most important thing, and it took me a long time to learn, because as you've seen, I've been a bum for most of my medical career, and it's only recently started working, is that as I got older and I had all of the various life losses and different things that occurred to me, I learned to care. And somehow we've got to keep doing that. And I think as an emergency nurse, and particularly the place I work, the ones that I love working with really do care about their patients. You've got to put a shield up for the crap, but you've got to leave a little hole there for your heart, and you've got to be able to shed a tear every now and then. And even talking about it, I do. But more and more, I feel emotionally engaged with my job. So it's not all beer and skittles, but it's something that you can only love it if you care about patients. And ask old people what they did for a job. That's really important. How can I help you? Remember what you can do. If you think back to the last talk, you can do everything that no other nurse can. Try and take the crap and not get too angry about it. Use it to give you energy. And the most important thing that a very wise old man, he's probably about my age, now my current boss told me, it's like it's like a magic number is 3 weeks. And for example, if you have a bad meal, you've got a sore stomach for a couple of hours. You go out for a big night and you've got a sore head for a day. You have a pimple on your forehead, it's about 3 days. But when you turn up to work and the CNC comes up to you and said, I've got to talk to you about that patient you saw the other day, that shift, and there was a complaint or there was a problem and somebody died, and that knot comes into your guts, and you're thinking, oh, God, and then you hear about this stuff, and then you think, it's unjust. And then you got to think, what I want you to think next time that happens is 3 weeks. Because you're going to go home that night and you're going to think, that's not fair, I'm a bit angry, I'm going to deal with that. Then the next day it's going to be the same. And then the next week it's not quite so painful. You're in week 2 and you can go a day without thinking about it, and you get a little bit angry because you're even more frustrated because you go back through the notes 25 times. And then you get to week 3 and you've had another 10 things bother you, and you had another 30,000 patients come through. And then when you get to 3 weeks, it's gone. So just think next time it happens, and I apply the 3 weeks, make it a self-fulfilling prophecy. Next time that shit comes in that you really don't want, just think about it and go, 3 weeks. I'll be over it in 3 weeks. There'll be a whole lot of other shit worrying me by the time that 3 weeks comes. Now, my utopia, it's very similar to everybody's utopia. I live quite close to where I work in my wonderful sheltered workshop that I call home. And if I arrive there and there's no ambulances, we both love that. And I know that hopefully they're down at Coogee Beach having a Sammy. I know they're out working. They've got a sea of empty beds, which we all love. Every patient in the department is drinking tea. I have a policy that everybody should be drinking tea. Because if you've had to give them a cup of tea, they might actually respond to you, you might feel nice, and you might ask Granny and Grandad what they did. The hospital manager comes down and announces that chocky bickies are now going to be provided in the tea room. We're really getting out there into gaga land. It's just not going to happen. But if it did, I would really enjoy that. And there's probably quite a lot of bed managers in the room here, but I want them to stop having endless meetings and go out and do something. Thank you.